I'm just going to kind of list these because I will address some of these in more detail, but basically the key factors are screening for delirium, which is so common and prevalent, having delirium prevention strategies, early surgery. 82% of patients are now having surgery within the 48 hours, nutrition, prioritising getting up. I'm going to talk a little bit about deep breathing, adequate pain management for all, particularly in dementia patients, where often we undertreat. And I think getting the person home as soon as possible if you have supports in place and follow-up community rehabilitation. Because I do feel being in hospitals are not the right places for people. I think when they're able to manage at home and you have good support structures around them, people do better at home. So teamwork is absolutely vital. So in any kind of guidelines, it does recommend multidiscipline input, having orthogeriatric assessment to rapidly optimise surgery or just to try and prevent delirium. So early identification of goals is really important, making them patient-centric, and to facilitate return to where people were living prior. So 85% of patients in New Zealand are now seeing a geriatrician during their inpatient stay, but I very much recognise, being a geriatrician, that it's not just the geriatric input, it's working holistically in a team. 30% of hospitals now in New Zealand have a shared care model, and I think that's really the way we would like to go, because I know when I visit a ward twice a week, things have happened in between my visits. The drug chart is being meddled with, things have been charted that I don't like. So if I was there all the time, there would be a greater continuity and quality control. I think time to surgery is absolutely critical. I don't think the 48-hour target is a good measure. I think the quicker, the better. People do better if they are operated on as soon as possible. And so there's a lot of education we've tried to do to make people be aware that in this group it's very clearly documented time to surgery is very important. They need to be prioritised. In our hospital, I became aware that anticoagulation and reversal of that was becoming a barrier to go to theatre timely. So we spent a lot of time putting protocols in place and getting everyone to agree on doing the same thing. So not individual practices would occur where people would sometimes wait days for something to wash out that really didn't need to be washed out at all. Our figures haven't really improved, which is disappointing when I looked at the latest registry, but I think we'll probably look better next year when those effects have filtered fully through. Also, another comment I wanted to make was that our hospital don't have dedicated trauma lists, we don't have dedicated neck of femur lists. So we're trying to vie for very precious time with everyone else. So certainly in hospitals that do have those resources will better serve these individuals. So this is a photograph I took at a conference. So that's just showing you, this study looked, I think, at 400 patients that went through a trauma centre. And this kind of shows you the hours waiting to surgery on the horizontal and the 30-day vitality on the vertical. And it's trying to illustrate that really at 24 hours, the mortality rate starts to creep up. So really, less than 24 hours is what we should be aiming for. So getting up and moving, it's all part of the standard protocols of what we need to do. In the latest reports from the registry, 92% of patients are given the opportunity to get up, to mobilise. Mobilise is quite it's not what you think of walking, it's really sitting up, even putting your feet on the edge of the bed, standing if that's all you can do, or sitting. Even that action alone is significant and important. But that kind of first day of walking, although it's tried, only it happens in 49% of patients, and there's quite a wide variation about that, which needs to be more closely looked at. And I think the results from the sprint audit might shed some light on that when they're processed. So basically, why do we do this? Because people do better. They're less likely to die, they're less likely to have in-hospital admission complications, they go home quicker, they are less likely to die at 6 months, and they are walking better at 30 days or even after 2 months. So that little action of getting someone up straight away is significant. What therapists should mobilise? Does the therapist matter? And I'm not trying to be critical of physios in any way, it's just that we know physios are a very precious resource. Basically, studies are showing it doesn't have to be a physio that mobilises the patient. People do better if they're mobilised. It doesn't matter who does it, as long as they're proficient in what they're doing. So people that received a physiotherapy assessment versus another professional, that they don't do any better. But certainly, if you get a person up quickly, anyone's going to do better. So this was, I think, also talked about last year. Does it matter how much physical therapy you do? There are studies that are certainly emerging, yes. If you just do kind of the one-up with the physio, you're probably not going to do as well as someone that's offered that 3 times a day. So it's just along the lines of getting people active, getting people moving, and it doesn't have to be by a physio. This particular study was carried out in a trauma centre in Melbourne, and they had 92 patients over 65 that they offered physical therapy, physiotherapy intervention 3 times a day. And they cut down the time in hospital by 10 days, and people did better. One thing I would say about that study is that people did stay in hospital longer than what I'm used to. I guess 21 days is kind of where I feel, but their median day was 35 days. So yes, it cut it down by 10 days, but maybe more into the realm that we would expect. But I think there is still a lot of merit in just getting people moving. Also, another comment, having a weekend therapy service I think is really important. I mean, it's so common to come back, particularly after a long weekend, and people have lost ground because they just haven't got up. Or there's been staff shortages, and people just haven't moved, and we've gone back. So any kind of hospital-based program that offers some kind of promotion around activity, eating, socialising, drinking, having some kind of routine, not kind of 50% of nothing, people are going to do better. Socialising, engaging in activities. You can call it any name you kind of want, but those are the key principles. So there are a few programs there, but basically I think that's something that the whole hospital should be doing, and that should be more normal care, not special care. Nutrition, I think this might be spoke about a bit later or perhaps tomorrow. But basically, I think nutrition is something that we don't do particularly well. So in New Zealand, about half of people may be routinely assessed for malnutrition, and 30% of people are malnourished. And then once we declare this, we do very little about it. So really, I feel where resources are limited, we should be offering high protein diets, food fortification, snacks to everyone, because protein needs are higher as we are trying to recover from this major event. And these are individuals who are often on the lean side in terms of their nutrition. So they're not starting with good reserves to start with. We now know that malnutrition is a stronger predictor for mortality than when you would compare it to the anaesthetic ASA grade or their comorbidity indexes, or even the time to surgery. So nutrition is not to be something to be minimised. Another sideways photograph. So this is just, I don't think this has been particularly well researched, but it's just an idea I've been interested in about giving people knowledge and education around breathing deeply, sitting upright after theatre. So this study was from last year. They had about 400 participants. They were having abdominal surgery, so different surgery, and probably one would argue they could have been a weller cohort of individuals as well that didn't have cognitive difficulties, but they had a physio come and spend 30 minutes, which is quite a long time, on coaching them to breathe deeply, to do this cyclically every hour, cough, and they ended up reducing the rate of hospital-acquired pneumonias by 50%, and they only had to treat 9 people. And they compared this to giving a booklet to people saying, oh, breathe deeply. So I think that's something, it's one of my bugbears. I don't like people having their food in bed. They should be upright, they should be eating, people should be sitting up. They shouldn't be lying in bed unless they're actively resting for their next period of activity. So I don't know, maybe we need to do a little bit more in this area. Hip fractures and dementia. I think recovery following a hip fracture is challenging for anyone, but it's particularly challenging for people with dementia or that are cognitively impaired. And we know that in people that break their hip, dementia is incredibly common. So up to 20% of people have a dementia, or up to 40% have some kind of cognitive issue. And we know that people that have dementia are more likely to die as a result of their hip fracture. So it can be anywhere between 35 to 55%. So it's pretty awful compared to people that are more cognitively intact. And people tend to have poorer recoveries and after having hip fracture surgery. So I did spend a bit of time thinking about the treatment of dementia patients in an inpatient setting. I do think we're not very good at treating pain particularly well. We have to actively think about that. But it's often like the Goldilocks thing, isn't it? You want to get it just right. You don't want to be heavy-handed and cause a delirium, but you don't want to undertreat and cause a delirium as well. So it's just about actively treating the individual and getting the right mixture. People that have dementia also benefit from getting up and being mobilised, so they should be treated with the same principles. But it is very hard to mobilise someone who might be actively hitting, spitting, kicking, who just simply doesn't want to do it. And I think there are fewer patients with dementia who do achieve that getting up at day one, because it is more challenging. I'd hate to think that people are just not given the opportunity. And there are different ways we need to think about approaching someone with dementia, particularly if they didn't use an aid beforehand, because simply putting a frame or a big device in front of them and asking them to follow a series of complex instructions is probably going to be very difficult, rather than saying, let's stand up. So there's ways that we can approach and do things, and we just need to use trial and error for each individual. Sorry, there's a lot on the slide. Basically, there are several studies, though, that show there is a benefit for those patients that have dementia, and if you give them physical rehab. But often, like was discussed by Sarah this morning, they are not offered rehabilitation wards. And I must say, we tend not to offer rehabilitation to patients that are in residential facilities. And when I say that, I'm not meaning service departments or independent villas, because those individuals are independent community dwellers. So we have just found that when we've looked at people that we've taken even from rest home levels and changed their outcomes. But it may be that we didn't persevere for longer, because studies have shown it may take up to 10 weeks compared to like a 3 week. So it may be that we just need to offer longer. We really rely on the Training for Independence program from ACC to go into the facilities, but I can't comment how intensive that is and how timely that is. Certainly from my experience from those that we've used Training for Independence discharge from the ward, they often may wait weeks for that engagement to occur, which is not meaningful in my mind. I think someone should be discharged and they should have rehab. So there have been studies though that show there's dementia and there's dementia. So those individuals with a milder dementia are very comparable to people with no cognitive impairment as well. So up to 91% will achieve their goals. Someone that's more moderately demented, perhaps 67% of time will achieve their goals. We also know from studies that if you discharge someone with dementia into a residential care facility versus a rehab facility, that those in the rehab facility will do better by quite a lot, particularly if they've got dementia. So success rates in one of the studies was comparing 91% to doing okay to 17% if you went back to the usual facility. There's also been studies that looks at quality of life, and people with dementia do like walking, and they do feel more happier walking than if they were wheeled around in a wheelchair. So they are just like everyone else, that the important factor is quality of life. So I don't know, I think it's when I do discharge people back to residential facilities, I don't know how well they go. I suspect from the studies that they don't do well. And who is responsible to oversee that they do get care and opportunity to thrive as well. So I think it's an erroneous thought to think fatally that this person will never walk again, because that isn't the case necessarily. So my final slide, and I don't know where the writing is gone. oh, it's very...
You made it fast.
This is not my slide, you can tell. I borrowed this off my colleague who's involved in the early supportive discharge venture that we've set up. It's receiving funding through ACC for each patient, and they accept referrals from the orthopaedic unit and our inpatient rehab ward. And the team will come and visit the patient on the ward, check that they're medically stable or they meet criteria, and then they go on and offer a comprehensive program at home. So they can offer up to 3 visits a day, which includes trained healthcare assistants who are trained in rehabilitation principles that are overseen by a physiotherapist. We don't have nurses as per se in this, it's more kind of therapists that are able to nurse and provide cares as well. It's a 7-day-a-week service. They have a weekly multidiscipline meeting that my colleague who's a geriatrician is part of. If you don't have a geriatrician part of the service, you don't receive funding. We can only take on kind of 4 to 5 patients at a time, but certainly it's made, I think, a positive progress to our discharge planning. It means we can discharge people a bit earlier from hospital and have some feeling that they're going to be looked after and that they're going to progress. If there are difficulties in the community, people come back in, but no one has come back in under this program so far. It just means that they can work on stairs and some of those higher goals in their own environment rather than in the hospital. It's been great during COVID. So that was kind of my thoughts. I haven't talked about the patient. I feel that obviously having a motivated patient is very important. Having a patient that has family around them to support them, that we can train with some therapy principles to assist with walking is really important. The fear of falling is really crippling in an individual, that anxiety. But if someone has a pre-existing anxiety problem, it can be really difficult. And so we try to employ psychology, deep breathing, and at the last resort medications to overcome people's anxieties. But those would be the individual factors that are really important. So it's really a team. We're all working together to try and help the individual.